Well, good morning, and thank you for the invitation. Happy to discuss the updates for 2015 on the diagnosis and prognosis and therapy of CMML. Let's see how you move. There we go. Okay, so I thought, first things first, let's talk about where CMML falls, or where CMML lies in the diagnostic spectrum of myeloid malignancies. And where it lies is really at the interface of the myeloid neoclassifications of from the WHO. So it's classified under a group of diseases called MDS/MPN. And no, that doesn't mean we're not sure whether it's an MDS or an MPN. There is a category that essentially groups diseases that have both biologic and clinical features of myelodysplasia, hallmarked by morphologic appearance and ineffective hematopoiesis, as well as biologic and clinical features of myeloproliferative neoplasms, hallmarked by leukocytosis, splenomegaly, and what is less well-defined, but I'm sort of coming to realize, a very important constitutional symptom burden that is the cause of significant morbidity in these diseases. So these diseases consist of CMML, which will be the focus of this talk, but also include JMML, which is often thought of as the pediatric version of CMML, although genetically and biologically they're distinct in many ways. Then you have atypical CML, which is hallmarked by profound dysplastic neutrophils, and a horrible survival. And then there's a wastebasket term called MDS, MPN, unclassifiable, where we know that the patients have those features of both ineffective hematopoiesis and myeloproliferation, but have no clear diagnostic bucket to put them in. The last group, which is a provisional group, but a very important group, is called RARST, which is essentially clinically defined by a platelet count of greater than 450 and the presence of more than 15% ring sideroblasts in the erythroid subset. If you have those two together, you meet the diagnostic criteria. Genetically, these are defined, as you would probably expect, by SF3B1 mutations, JAK2 mutations, and as far as I know, they are the only non-MPN disease that does have a significant portion of calreticulin mutations as well. So why care about CMML? Why do I care about CMML? Well, it's a rare disease in general, but it's more common than we think. The incidence is about 0.4 per 100,000, which, to put in perspective, is about the incidence of primary myelofibrosis. It's a higher incidence than chronic myeloid leukemia, and so it happens pretty regularly as myeloid neoplasms go, and we think that it's underdiagnosed, in part because there's been a sort of dynamic classification schema. CMML was previously classified as a subtype of MDS. And then it also in part because there really is no compelling reason to stratify MDS for CMML in the clinical management, in the everyday clinical management, because there exists no specific CMML therapeutic, and we hope that changes in the next few years. Secondly, it's among the most aggressive chronic leukemias, with a median survival in our international cohort of about 34 months. But there is a high risk subset where that survival is less than a year. And then compared to the MDS-MPNs, it actually represents a disease that can be studied because there are sort of differentiating features. You have to have a peripheral monocytosis. If you don't have it, you don't have CMML. And so that at least provides a sort of pivot point to where we can focus on this disease and learn about it in a cohort type setting. And then there have been, surprisingly, for such a rare disease, I think pretty dramatic advances in the biologic, genetic, and clinical understanding of it. And so that's what I want to focus the talk on, sort of what's new in CMML. So CMML, just so we're all on the same page, as I said earlier, is defined by peripheral monocytosis. That means you have to have more than 1,000 monocytes in your peripheral blood, and those monocytes have to make up more than 10% of your differential. If you don't have it, you don't have CMML, based on the WHO. Unlike MDS, CMML does have a fair amount of myeloproliferative symptom burden, so 25% of CMML patients have splenomegaly. An undisclosed amount, but anecdotally a fairly large amount of CMML patients have the typical constitutional symptoms that we sort of have learned about predominantly from myelofibrosis. There is a defined genetic fingerprint of CMML, even though there is not a single mutation that defines CMML. There are groups of mutations that tend to be highly specific. So for example, ASXL1, SRSF2, and TET2 occur up to 50% of patients with CMML. And so that's much higher than other myeloid diseases. And in fact, if you look at patients who have co-mutation of SRSF2 and TET2, or ZRSF2 and TET2, there is a 96% specificity for the diagnosis of CMML. And again, as I alluded to earlier, it's a disease with a poor survival. So the median survival is 32 months. And unlike MDS, there is no therapeutic that we know that alters this dismal natural disease. And so there's a huge unmet need for the development of efficacious therapeutics in CMML. So when I think everything in terms of CMML, I just, in my mind, bin things into three groups: diagnosis, prognosis, and therapeutics. And that's how I'll bin this talk. And lastly, if we have time, we can talk about some of the biologic insights that may inform future therapies in CMML. So how do you diagnose CMML by WHO? So there are really a few key things. So first, you have to have the monocytosis, like I said. Second, you can't have the Philadelphia chromosome for obvious reasons. And then you can't have more than 20% myeloblast, because then you'd be M4 or M5 AML. Now the point number 4 is not a complete requirement. You don't have to have dysplasia to have CMML. And in fact, oftentimes, if you look at the morphology of patients with this disease, the dysplasia is often subtle. And so there are often cases we have subtle dysplasia, monocytosis, normal karyotype, and don't have a clear, convincing diagnosis of CMML versus reactive monocytosis versus something else. So I think identifying clonality in CMML is critical, as so far as you can differentiate those patients that have perhaps reactive monocytosis from viral infections or others, or a clonal malignancy. And then the other thing is that the WHO classifies these entities into two groups. And it's very simple. If you have 10% blast or less, you have CMML1. If you've got 10 or 11 to 20, you've got CMML2. And it's clear that those two groups behave differently, the latter being a overall worse disease. So a couple of things that sort of in my clinical practice I've implemented within the last, say, 18 months when I see a patient with CMML. So when I see a patient with CMML, in everybody, I perform next generation sequencing. And so in our institution, we have a 36 gene panel, but there are a variety of these panels that, if you look at their content, the genes that they sequence, they all include the really key important genes to look at in CMML. And so the reason why I do this, really there's one of two reasons why we do this, is because Torsten Hofferlich's group published in Blood that if you sequence only 9 genes, and again, these panels include all of these 9 genes, you can find one mutation in 93% of CMML cases, which is distinct from MDS, where it appears that there is slightly more genetic heterogeneity. You can only sequence 9 genes and you'll find the clonal marker. And that's critical, again, for that subtle dysplasia, that question, is this reactive or is this clonal? So we do this in every patient, and it's very informative. Another update is basically asking the question, is that 10% cut point the best cut point for CMML? In MDS, we know that based on the RIPSS and even the IPSS that you can further refine the risk stratification of patients by looking at the blast counts at less than 5% or even less than 2%. And so this is a paper from the German group published in Leukemia Research that showed that there may be 3 groups of CMML that we can reclassify this disease at. So CMML 0, less than 5%, CMML 1, 6 to 10, and CMML 2, 11 to 20. On the right is a panel of our data, essentially from an international cohort that we put together of 8 centers across 3 countries, and showed something slightly different, but showed that really if you look at patients that have less than 5% blast, they do uniquely different. So if you have less than 5% blast and you have CMML, you're going to do better than those with 5 to 9. And in our cohort, the patients with 5 to 9 or those with higher than 10 did approximately the same. But I think the general theme is that the current cut point for CMML1 and CMML2 is under scrutiny, and perhaps in the next WHO revision, you'll see that they're further refined into at least 3 categories. The other thing that I think about when I'm seeing a patient with CMML diagnostically is this concept of overlapping and overlap syndromes. So there are a couple things to think about. So first is historically there have been patients with CMML that have eosinophilia and have a PDGFR beta more commonly, but even PDGFR alpha gene fusions. And this is relevant because these patients seem to be uniquely sensitive to imatinib. Patients with CMML that don't have this fusion are completely insensitive to imatinib. The WHO revision in 2008 actually pulled those patients out and put them in a genetically defined category called people with PDGFR beta fusions. But I have to say, historically the idea has been, if you have eosinophilia in a CMML-like patient, check for this. But I'm starting to check for this in every patient. We have a case report that we just published that we found this variant, this fusion, in someone who had no eosinophilia. And so because the treatment management is drastically different, I'm starting to order these in everybody, either by the FISH break-apart test or as part of one of the comprehensive genomic profiling tests, the Foundation Medicines, the Genoptics Next Course Completes of the world, which include these rearrangements. And so I include that. It's something that I think we all have to think about, even though the incidence is very low. The second thing that we have to think about is the whole issue of systemic mastocytosis. So there is a WHO-defined entity known as systemic mastocytosis with associated clonal hematopoietic non-mast cell lineage disease. And it just turns out that the most common associated disease is CMML. So there is an entity of systemic mastocytosis and CMML that does exist. The etiology for this co-occurrence is unclear, although I think there was an interesting paper that demonstrated that SRSF2 P95H mutations are prevalent in this condition, suggesting, and of course SRSF2 mutations are also highly prevalent in CMML, suggesting that there may be sort of a common genetic origin. But it's an entity that exists, and it's an entity whose clinical picture is different. So patients that have this have the B findings, the C findings that you can often see in patients with aggressive systemic mastocytosis. I think the therapeutic strategy is unclear and generally sort of geared towards the disease that's causing the most symptomatic burden. So the patient is severely cytopenic and nothing else, perhaps you would focus on that. But if they have mastocytosis-related symptoms, perhaps you would gear your therapies to that entity. There's also what we are terming secondary CMML. So Dr. Garcia-Manero published a paper in Blood that sort of described a cohort of therapy-related CMML, and their behavior and their antecedent chemotherapeutics were similar to that of therapy-related MDS. They do exist in about 6 to 12% of CMML cases, and they're important to recognize. And we published a paper in where we noticed that patients that had bona fide MDS for a long time transformed to CMML. And it wasn't a sort of pathway to AML. They had CMML and they stayed in CMML for a while. And when we profiled them sequentially, we found that those patients had either expansion of a signaling mutation like NRAS or Sybil, or interestingly, the acquisition of ETV6, which in our cohort, albeit small, was highly enriched, is never seen in de novo CMML, suggesting that there may be genetic differences between this secondary CMML type and de novo. So the other thing that I think was really important was a paper in Blood by Eric Soleri. So his lab looked at whether we can refine the diagnosis of CMML by looking at the different types of monocytes. So it's been known for decades that monocytes are classified into the classical monocytes, which are more inflammatory, the intermediate and non-classical monocytes defined by their 14 and 16 expression by flow cytometry. And what Eric did is essentially ask the question, is the partitioning of monocytes in CMML different? And the answer was dramatically yes. And so that all patients that he looked at were strictly localized to the classical monocyte subtype, as you can see in this flow cytometry part. And what was interesting is it was highly specific for CMML. And so, for instance, in clinic, we'll often get a patient that has fibrosis and monocytosis. Do you call that patient myelofibrosis with monocytosis, or do you call them CMML with fibrosis? It may be a semantic issue, but at the end of the day, a strategy like this may help refine that, because whether you looked at aged match controls, non-CMML MPNs, MDS, they all had a normal partitioning of monocytes, whereas the CMML group was highly specific. And in fact, when you looked at the sensitivity and specificity, the AUC was highly significant at 97%. So I think this is a very important thing. Actually, since this paper came out and Eric spoke to us about this, we've convinced our pathologists to sort of onboard a CLIA certified test where we can now at Moffitt run this as part of the EMR to help in the diagnosis. So what about prognosis? I think for a rare disease, it's a good and bad problem. There is an inordinate amount of CMML prognostic model, which is great because that means that we're thinking about risk stratification, which is probably the most important thing we can do for our patients at the moment, given the lack of therapeutics. But it does muddy the water because when organizing clinical trials, when trying to speak the same language, it's not like MDS where there are a lot of models, but the overwhelming majority of clinical trials are based on the IPSS or IIPSS. That's not the case in CMML. And so we put an international cohort together to try and answer the question, what is the best model? It was over 1,800 patients. Each patient had over 70 discrete elements, including genetic information. And we calculated all the models that we had data for at the time of first visit to the institution. And what we found, as Rami mentioned, is that they're all valid. They all work. Even the RIPSS and IIPSS that wasn't initially constructed to discriminate patients with high white count CMML worked in our hands. And so the moral of the story is that they're all valid, but they're all modest. They're all sort of average at risk stratifying patients, and not one was better than another statistically. So these are the ROC curves, and we also performed a C-index statistic that told us exactly the same thing. There wasn't a winner. So that sort of lends the question, should we add molecular profiling to our clinical models? And the answer probably is going to be absolutely. There's already some groups that have constructed models. So this is from Eric Soleri's lab again, where they first showed that ASXO1 is independently prognostic and used that in their model. So this includes ASXO1. And this is from the Mayo group, where they also showed that ASXO1 is independently prognostic and added to their clinical Mayo model. What's important to know about ASXO1, if you're getting these reports from Foundation or wherever, is that the prognosis is only derived from the frame shift and nonsense mutations. There was actually a publication by the Mayo group that said ASXO1's mutations are not predictive in CMML or not prognostic in CMML. Well, that's because they included the missense mutations. So it's important to know it's the frame shift and nonsense mutations. So we were able in our international data set to show that ASXO1 is independently prognostic, but we also showed that Sybil mutations are independently prognostic, and we're trying to use this data now to come up with a consensus model where hopefully it performs better than existing models, and we can use as sort of a agreed risk stratification going forward. So let's talk a little bit about treatment. So the treatment of CMML is not the same as that of MDS. And so it is not the case that if you have an asymptomatic, in my opinion, that if you have an asymptomatic high-risk CMML patient, you automatically should treat them with a hypomethylating agent. In MDS, you can make the argument that that's the case because there is a phase 3 trial that clearly showed a improvement in overall survival. However, if you look at the number of patients in the AZA-001 trial that actually had CMML, it's on the order of a dozen or so. And so you can't do subgroup analysis, and in my opinion, you can't extrapolate that information to CMML. And so even though it is approved, hypomethylating agents are approved for CMML, FDA approved. In my opinion, they're not been proved to be disease modifying. What they do have is activity. So if you look at MDS IWG 2006 criteria, for instance, you do see that hypomethylating agents have about the same response rate that they do in MDS. And so that's one point. But in my opinion, you can't then now say that they also improve survival. Are there any predictors of response to hypomethylating agents? Well, the historic ones have been ones that really aren't able to be clinically translated, although important, like CJUN and CMIB. I know Rami published a paper in where he found that patients who received hypomethylating agent but had splenomegaly and leukocytosis did worse in terms of overall survival compared to those that didn't. But I think a really important paper was recently published from Ken Figueroa's lab that essentially took patients who were either responders or non-responders and did in-depth epigenetic profiling. And this is in patients who had decitabine. And what she was able to show is that there was a clear hypomethylation signature that predicted response to decitabine with, again, a very nice area under the curve. And what was nice is that some of the demethylated regions were near important genes like CXCL7, CXCL4, and she was able to show that the addition of these to culture induced resistance, suggesting that it wasn't just a molecular signature, that there was biology behind it that really supported this as a potential predictive marker in the future for CMML. I know they're working on 5-azacitidine and other signatures, which will hopefully be published soon. So what about cytoreductive agents? There are a series of cytoreductive agents that have been tested in CMML. The short answer is if the goal is reduction in splenomegaly and improvement in white count, there are agents that you can use, but again, there's no clear disease-modifying criteria. I would mention that there's been only one phase 3 trial ever done in CMML, and that was by the GFM, and they compared topotecan to Hydrea, and they found that actually Hydrea won. And so these appear to all have cytoreductive capacity. And in my practice, I pick this agent depending on the performance status of the patient and the degree of myeloproliferative symptoms. It's summarized in that sentence. There also have been many small retrospective analyses looking at the impact of allogeneic transplant in CMML, and I think the short answer here is that it appears that based on these retrospective studies that the same bottom lines from MDS can be extrapolated in terms of outcomes, in terms of long durable remissions in a minority of patients. Whether the important work that Dr. Cutler has done in MDS in terms of risk stratification applies to CMML is completely unknown. So what about measuring response? So this is an international working group criteria that was led by Dr. Savona, who put together a suggested response criteria. And I think this was very important because there wasn't even a set of agreed upon criteria that we could look at in clinical trials to ask if a therapeutic agent was effective. So we've started implementing this in our clinical trials, and we hope to see in the near future whether this criteria holds up with respect to survival and patient improvement, and hopefully can be translated throughout clinical trials to be sort of an agreed upon criteria that we all use. So what's my management algorithm in my clinic? So the first step that I do is obviously we make sure that they have WHO-defined CMML. And in our practice, we do the sequencing, and only recently, but we do this on everybody now, have started implementing this monocyte subset partitioning and assay to sort of have a 100% sort of agreement that this is CMML. And then again, the most important thing we do is risk stratification. And like Rami spoke, we use the Mayo and Global MD Anderson and consider profiling for ASXL1. If the patient has higher risk CMML, we refer them all who are fit for transplant to transplant. Again, this is sort of based on our anecdotal experience, and it's unclear whether there should be this partitioning of low risk, high risk CMML with respect to transplant decision. Those that have, so this is sort of the algorithm I use. Those that have no symptoms and are lower risk, I observe. And I've had patients that do well for several months to years with no therapy versus clinical trial. If they have no symptom and are higher risk, I strongly encourage a clinical trial, even if they're asymptomatic. But if not, I observe. Of course, there are always sort of gray areas, but that's typically my management strategy. If they have symptoms, I tailor it to what the symptoms are. If they're rapidly proliferating, if their spleen is increasing dramatically, I don't think you can wait for hypomethylating agents to work. So in those cases, we do the cytoreductive agents. In patients who are young and in extreme pain or feel horrible with respect to constitutional symptoms, I induce them. And in those that are, say, older and have, some night sweats, perhaps we start Hydrea. If their main issue is cytopenias, we do hypomethylating agents. So I don't have that much time left, but I just want to quickly say that there are the biology has dramatically advanced in CMML. There are now good models, and I think it's a great time to start thinking about investing in therapeutics that can really alter this disease. There are the three big genes that are mutated. The models are there. ASXL1, TET2, and SRSF2 models have all been published. There's a really nice NRAS model that gets CMML and has GM-CSF hypersensitivity, which we think is a hallmark feature of the disease. And so the tools are there really to do preclinical work. But just briefly, we published that GM-CSF hypersensitivity is a feature of CMML, and we also published that it's targetable. And so what that's led to is several clinical trials that have either been completed or are in progress targeting this GM-CSF pathway. One such trial is ruxolitinib. The manuscript is complete, and we're submitting the phase 1 trial now, where we tested 4 dosing cohorts, found that it's completely safe. There's no cytopenias, actually, in comparison to myelofibrosis that we saw. We see broad range activity from reduction in splenomegaly to hematologic responses. So this has been very encouraging, and we have other drugs coming on. This is one phase 3 trial, the second phase 3 trial that'll be done in CMML that I think is important. That's randomizing, well, that's the old one. There's another one coming up that's randomizing patients to Hydrea or Hydrea plus decitabine, which I think will give us a really important signal as to what exactly hypomethylating agents do. So in conclusion, mutational analysis and monocyte profiling can help in the diagnosis. We're doing that now. There's many tools for prognosis. They're all about the same, but we're trying to get a better one. This therapeutic strategy should be tailored to the symptoms, and there's been an explosion in the genetic and molecular understanding of CMML. So I think now's time for really new targeted clinical trials to be done. So thank you very much.